Hi, good morning. This is Blythe Ryerson from the Division of Viral Hepatitis at CDC. I'm the Associate Director for Science in the division, and I first want to thank you all for joining us this morning. I know many of you are busy getting ready to take time off over the next couple weeks, and we do greatly appreciate you joining during this busy time. Many of you are aware that last month we had a publication come out, an update to our national hepatitis C prevalence estimate. And in that, we estimated that 2.4 million people were RNA positive in the United States. While we were working on that paper, we were also simultaneously working on state-level estimates. And that's what we're here to talk about today. The primary goal of the state-specific paper is really to develop a methodology to estimate the burden of hepatitis C across the states in a standardized way. And I know, well, it's very challenging to do this kind of work for a couple of reasons. You know, at CDC, we're limited on the type of data that we have. For both of these papers, we're basing our estimates on the NHANES, which is the National Sero Survey. And there are limitations to that, of course, particularly for the populations most at risk for hepatitis C. And so we've done some work to try to mitigate those challenges. And then also, of course, we recognize that there's much heterogeneity at the state and local levels and differences in populations and risks. And so our models are really an attempt to try to standardize this methodology to take into account all these differences, realizing that state and local jurisdictions are going to have estimates of their own that will be more precise, and we value those and look to your leadership to provide those. But through this kind of iterative process, Dr. Eli Rosenberg has remained steadfast in his efforts to continue to improve these kind of national standardized estimates. And the new paper that we're here to talk about today is being posted today to the JAMA Network Open. And you know, we would have liked to have provided this webinar earlier before publication, but because of journal requirements, we weren't able to do that. So I think it's being posted any time now, perhaps during this webinar, and so look for that, and we can certainly send a link out after the call. But I'm pleased to have worked with Eli on these new estimates, and I'm just going to introduce him now and then turn it over to him. So Dr. Rosenberg is an associate professor in the Department of Epidemiology and Biostatistics at the University at Albany School of Public Health. His work focuses on challenges in measurement of disease burden and disparities across many of the diseases we work on in the center here at CDC. He is co-PI of a cooperative agreement we have here at CDC with them aimed at modeling timely questions for public health action, such as the work on hepatitis C prevalence being presented today. So with that, I'm going to turn it over to Dr. Rosenberg.
Great. Thanks so much, Blythe, and thank you everybody for joining today. As Blythe has just introduced, we're going to talk today about a state-level methodology and set of estimates for prevalence of hepatitis C in U.S. states and District of Columbia, targeting the years 2013 to 16. That's being published today. And before I get too much further, I want to recognize that this work has been supported over the last number of years by this cooperative agreement that Dr. Ryerson mentioned, the NCHHSTP, Epidemiologic and Economic Modeling Agreement, or NEMA, which has been a really fun mechanism to support this kind of work across the disease areas listed here. And it's really a great example of an academic and public health collaboration to make models that are really actionable for public health decision-making at various levels. So with that, I'll turn to just the outline here. We'll give a little bit of background on the endeavor here that we're talking about, hepatitis C prevalence estimation, and step through an overview of the methodology that was employed in this analysis, which is really an extension of earlier methodologies that we and others have published over the last several years. And then I'll actually also work through an example to really just make the computations feel a little more real and tangible, and we'll work through a specific jurisdiction as an example. And then I'll present results for jurisdictions, and we'll spend a little bit of time with that. And then we'll talk you through some of the limitations and strengths, some of which Blythe has already mentioned, and then we'll just wrap up with some concluding thoughts. So as everyone collected on this call knows that having an accurate sense of the state-level burden of hepatitis C infection is really important and informs much of the work we do, be it policy work, allocating resources, advocating, or planning efforts towards prevention, treatment, or elimination. And the prevalence of current infection per RNA is one of the ways that we quantify prevalence. Think about prevalence. And as has been mentioned, the NHANES, the National Health and Nutrition Examination Survey, is one of the ways that this has been traditionally monitored in the United States. So this is the NHANES, it's a nationally representative residential survey, so representing households. And we'll get back to that issue of the residential population in a little bit. And in many jurisdictions, this can be challenging to measure directly out of case surveillance for a number of reasons. And so what we really sought here was to develop a unified approach for estimating in all jurisdictions prevalence from survey data. And the way this is done is that we developed statistical models that let us use a national total derived from the NHANES with some local information that signals where the national infections are distributed in states. And the data sources that we've been using for that are the National Vital Statistics System, the NVSS mortality files, i.e. death records, and then population size information from the American Community Survey, the ACS. So as I said, this is really a continuation of a lineage of work, starting with a set of estimates we developed for 2010 that used an earlier version of this approach, but also an earlier version of the data through 2010. And as we'll talk about in a moment, and as everyone on this call likely knows, that a lot has changed since 2010, and that really more timely estimates are needed. And just weeks ago, colleagues from CDC, as well as others, published in Hepatology an updated national estimate for 2013 to 2016 from the NHANES. That's a national number, and so now this work that we're about to talk about revisits that national number with state-level approaches and results. And when we think about updating prevalence over the last decade, we need to be cognizant that so much has changed in the epidemiology of hepatitis C over the past decade. As we all know, there's after years of declining incidence, as depicted in the slide on the left, really through the late 2000s, we're seeing an alarming proportional rise in incidence among younger persons, and particularly younger persons who are injecting drugs secondary to the opioid epidemic. So new approaches need to think about how to handle this still relatively minor but important change, minor in terms of prevalence, but important changes in incidence that are occurring in younger persons, which we think will have a modest increase in prevalence, result in a modest increase in prevalence. Two other forces are, of course, at play. Mortality, particularly in older persons in a higher in a higher prevalence 1945 to 65 birth cohort, would serve to lower prevalence. Furthermore, with the availability of highly effective curative therapies, and as barriers to those are removed and scaling up is occurring, we would expect that treatment would also serve to lower prevalence. So as we think about the task of estimating prevalence, we need to be mindful of these countervailing forces that might serve to raise and to lower prevalence. It's a complex tug of war. And so in the next few slides, I'll sort of outline the approach that we've employed to get at these challenges. So I'm going to graphically step through the stages of this analysis. The first approach starts in a relatively naive way. what we do is we take the NHANES national results and we break them out by demographic groups, age, sex, race, and so forth. And we allocate infections to individual jurisdictions based on their demographic distribution and the prevalence of hepatitis C in those groups as shown in the NHANES. So for the epi-minded folks on this call, this is just standardization. And if you standardize the national, each state to the national NHANES results, you get a picture that looks like this. And I'll say this is not, this is a very naive picture. This is not correct, right? Because this is really just distributing out the national picture of infection to each state, but doesn't really account for local epidemiologic realities or really transmission patterns of Hep C. But it's a reasonable first guess, and indeed it's a first guess that, that some have done in the past absent additional methodology or data. And so what we do is we start with this sort of first pass estimate at standardizing out prevalence from the NHANES. But then we take it a few steps further. We know through mortality data some very informative, there's some very informative pieces that help us distribute out where infections might be, and in a more nuanced way than step one did. The map on the we just illustrated two maps on the upper right. The left map shows hepatitis C mortality rates. So this is not prevalence from hepatitis C. This is mortality rates as reported on death certificates. And so we think of this map as being highly informative of where infections may be. Even if it's not prevalence itself, mortality is a strong signal of where a person's living with infection might be. And so what we want to do is adjust our map from number one by the picture of mortality from hepatitis C. But we also know that mortality may be illustrative of persons infected some time ago and their prevalence, but it's not going to be very informative for where recent infections are occurring. And for that, we turn to the picture on the right, which is narcotic overdose mortality. And a growing body of literature has shown the extremely high spatial correlation between places where narcotic overdoses are being seen and acute hepatitis C infections. And so we use narcotic overdose as a signal for those places experiencing acute transmission. And so the idea here is that we use these rates for both hepatitis C mortality and narcotic overdose mortality within age, race, and sex strata, so controlling for those factors. And we basically let states that are more over or underrepresented in these rates help to reallocate the infections in part one. And so in order to do all of that, we need to figure out a way to combine the maps in the upper right corner. And what we do is we essentially take a weighted average of these maps within birth cohorts. And the idea being that persons born longer ago, so let's say, for example, before 1945 in this table, would be most weighted to the map on the left. We would say that the mortality distribution of hepatitis C would represent their prevalence picture, and that really they would not be represented in the map on the right, narcotic overdose deaths, which are really associated with younger persons. On the converse here, let's look at the bottom row in this table, we determined based on some analyses that we should be weighting the map on the right for to be about 62% and the map on the left for 38% for persons born 1970 or later, reflecting that much of the hepatitis C in that population is attributable to more recent injecting behaviors. And so there's a number of analyses that informed these weights, and indeed the paper goes into a number of sensitivity analyses that consider alternatives to these weights. So the reason we do this is to get sort of a unified estimate of how to distribute infections according to mortality in these age, sex, and race strata. And those become these what we call mortality ratios in the paper. These mortality ratios are multiplied by the initial map that you get on part one, that naive map from NHANES, we essentially multiply that map by these mortality ratios to get an adjusted map that's adjusted for these two mortality inputs that represent older and newer eras of infection. And so that gives us a map here. It's blurred out because we're going to go into more detail about this map in a moment. An important other step to consider is a final step that recognizes that the NHANES is a residential survey. Certain key populations, particularly the incarcerated, the unsheltered homeless, are not represented well in that sampling frame. And we did some additional steps, essentially additional literature review and analyses to help add back in populations that may have been missed through NHANES. And those get added on top of the state level estimates. These together yield final prevalence estimates for the total U.S. population. Here's a quick depiction of the data sources involved. There's a number of data sources. I think what's important to show here is that this represents a pooled analysis of nearly 2 decades of NHANES data with using all available hepatitis C results during that time. Time is modeled in here, so we were able to sort of understand recent eras of NHANES. I also want to point out we're using the 2 different types of mortality from the National Vital Statistics System, each contributing hundreds of thousands of deaths that provide that local information. So in the case of hepatitis C mortality, we have about 270,000 qualifying deaths and about over 500,000 deaths, narcotic overdose deaths that were used for that part of the analysis. So there's a lot of data being used at the local level to inform this work. I'll just say one quick thing about that last step 5. The populations not included in the NHANES were really considered at the state level 3 different populations. The first was the residents of nursing homes, the second is unsheltered homeless, and the third are the incarcerated. For each of these approaches, populations, we used slightly different approaches, but the general idea was that we used publicly available sources to understand the state-level population sizes of each of these 3 populations. And then we obtained, through various means, estimates of hepatitis C prevalence in these missed populations and essentially multiplied them. So for residents of nursing homes, we assumed that the sex and age-specific prevalence in NHANES, if standardized to the unique demographics of nursing homes, would be sufficient. For the unsheltered homeless and the incarcerated, we went to the literature and really synthesized available articles during the analytic time frame that summarized studies that were conducting general prevalence studies in these populations. A lot of that work was summarized well in the Hofmeister paper that informed the national update. I'm going to just quickly step through an example for Kentucky that helps. I think this will help make the depiction earlier feel a little bit more real. So first we go to step 1, which is standardizing the NHANES national work to the population structure of Kentucky. And what we're going to do here in this example, it's sort of gone over in the gray box in the lower right, is we're just going to consider a single demographic factor, birth year. And that's really just because it's not going to fit on a slide if we have to show all the demographic groups. So this is for illustration purposes only. But the basic idea here is if you turn to the NHANES and say, well, what's the prevalence in the national NHANES of hepatitis C RNA by birth year, you get estimates that look about like this. About 0.21% for persons born before 1945, about 1.6% for persons born 45 to 69. Notice it's a slightly different definition of the birth cohort. And then greater than or equal to 1970, we estimate about 0.46%. So if you then turn to the census and look up the adult populations in these groups, you get the middle table on the right, and you would multiply these two together to get a naive sort of first guess estimate at hepatitis C prevalence infections in Kentucky in these age groups. And if you sum these up, you'll get that sort of an initial statewide estimate. But again, this assumes that Kentucky has the same underlying hepatitis C situation as the U.S. as a whole. It doesn't really consider local epidemic factors. But this is Again, if you didn't have anything else other than the NHANES and the census, this would be what would be a wise thing to do. So we start with this work, and then we next turn to the mortality data. And so first we're going to start with hepatitis C mortality. So the table on the left shows the per 100,000 death rates from hepatitis C reported to the National Vital Statistics System. Obviously, there's sort of several factors at play. Clearly, mortality is always going to be generally higher in older groups. And then there's also going to be an aspect that's higher rates due to excessive amounts of hepatitis C. And so that's why we do these things within strata. But the basic idea here is that if you, these left three rates in the table represent the hepatitis C death rate in Kentucky per 100,000 per age group. The middle table shows the national levels of hepatitis C mortality. And so if you divide on the rows, for each age group, these mortality rates, you get essentially a mortality ratio, or sort of a standardized mortality ratio for Kentucky. And what we see here is that in older persons, in the oldest age group, that value of 0.72 reflects that the mortality rate for Hep C in this oldest group in Kentucky is about 28% lower than the national rate. But if we sort of go down to the the younger group, 1970 or older, we actually see about a twofold death rate of hepatitis C in younger persons, so this would sort of represent an excess of sorts. We would sort of suspect an excess in prevalence in that age group based on this excessive mortality in the younger persons, but not so much for the older groups. So that's hepatitis C mortality. If we now go to the next step, looking at narcotic overdose deaths, we see these data. Notice the map in the upper right has changed to something that should be familiar to probably many of us if we watch the news. This is sort of the national overdose map picture. Now if we look at the death rates per 100,000 in Kentucky versus the national picture, we see rates like we see that Kentucky has between 1.6 and 2.1-fold the overdose rate compared to the national for a given age group. So older groups we see about 1.61, 2.1 in the younger age groups. So this would represent that Kentucky is relatively overrepresented on narcotic overdose deaths, and we would therefore use this information to say, to allocate a portion of infection, sort of more recent infections to Kentucky because of their sort of excess on overdose, signifying where we might suspect injecting risk factor. So we have to next put these pictures together, and that's this weighting process here in step 3. And so what we essentially do is we take both of those ratios that we derive, one for Hep C mortality, the other for overdose, and we weight them according to the weights that we described earlier. Essentially, older persons are going to be more we are saying are more reflected in their hepatitis C mortality ratio. Younger persons are going to be more weighted towards the bottom picture, the overdose mortality ratio. And when we put these together, we get sort of a weighted average that looks like the right. Okay, and that essentially shows that younger persons are about twofold, or we would expect are experiencing like twofold higher levels of prevalence. So this young 1970 or later group, by a twofold higher prevalence rate compared to the national, whereas we see maybe about a 1 or slightly less than 1, or sort of a lesser infection in the oldest groups. So by combining these two streams of mortality information, we sort of see that Kentucky will emerge as higher prevalence in this younger group, but not so much in the older group. So this is how we sort of bring the mortality data together to come up with a sense of where the local patterns are. So in our final step, we have to then bring these combined mortality ratio to our original prevalence map. All of that work up until now was looking at mortality, a signal of where infections are, but we still have to apply it to a total. And so in our last step, we take that first naive estimate of prevalence from standardization in NHANES, and we simply multiply within age groups by these state effects for mortality. So this essentially ups the youngest group from 7,000, in 81 cases there, or infections in persons born after 1970. We're going to multiply that by about 2, whereas for the older group, we're going to actually multiply them by 0.72 and about 1 for the birth cohort in the middle. And so if you do this process, you get an adjusted estimate on the right, which forms our final estimate. And here it says about 1.1%. I'll actually comment that with the additional demographic adjustments and the missing populations issue that we'll talk about again, that the estimate for Kentucky is actually higher than this, but this is an illustration only. But this is the idea, that we take our adjusted mortality-based estimates and multiply it by the NHANES estimates to get a final estimate. So next, I'll step through some national results. So if we apply this synthesized NHANES and vital statistics approach to all U.S. states and the District of Columbia, what do we get? So this map shows the prevalence rate, so per 100 rates or percent, in the U.S. in 2013 to 16. I also just want to comment for a moment on the time frame, that this is 2013 to 16, but it's really representing an average period prevalence over this time period. So one way to think of this is approximately the prevalence on January 1st, 2015, the midpoint of that interval. We'll talk about again at the end that this is, of course, an era of change, and that prevalence may yet be higher or lower since that point. But it's important to think of this as sort of the midpoint of this interval. So a number of aspects pop out when we look at this map. One is that the West region, the West Census region, has about 10 out of 13 states with prevalence above the median, which is about 0.9% prevalence. And so we see definitely a concentration of infection in western states, which is consistent with earlier estimates representing just a historical burden on the West Coast. Another important piece to point out is that when we look towards the East Coast, that states that are members of the Appalachian region are also represented. So notably here in this darkest blue shade, we see Tennessee, Kentucky, West Virginia. 3 of the 10 highest prevalence rate states are represented in these regions, and this region, and that's actually the 3 I just mentioned. So we see some very high prevalences there as well, and then we also see Oklahoma, New Mexico, Louisiana coming out in the highest quintile as well, which is consistent with some earlier work in those areas. So these are results for prevalence rate. In a moment, I'm just going to show the full table so that people in your given jurisdictions that you could have a moment to see what those results are. I'll also point out these are results that are after adding in the populations that are not sampled by NHANES. So this is total adult estimates, not just the NHANES population. This slide represents persons with hepatitis C RNA, so now total persons. And so this is now also incorporating population size, so states may pop out differently in this depiction versus the previous one. Higher population states are going to be more emphasized in this display. Some important facts, about half of all infections, 52% of infections, are within 9 states. And those are states that are both high population, high rate, or both. So now we see other high population states pop out: Texas, California, and so Florida. But then we also see again that states that are member of the Appalachian region have very high numbers of infections. So here, Ohio, Pennsylvania, and so forth pop out as areas with high concentrations of infection. New York as well. And so again, just another important view when we think about the total burden that that we need to be thinking about in our efforts. This is an important view. We think about how many people affected. Tennessee and Arizona are states that were both highly ranked on prevalence rates as well as persons with hepatitis C infection because of both high per capita burden and also high population size as well. So the next slide is actually all the results sort of put out in one display, and I'll just sit here for a moment so that people can have an opportunity to view their estimates. Of course, they're also now being put online by the journal, so you can go look those up in a moment as well. And I'll, in the next slide, also just say some of the additional results that are available in the paper because we couldn't fit everything into the slide here. But these are really the core results looking at in the total adult population, the estimated number of persons with RNA positive results, as well as the estimated rate per 100, all based on the model. Okay, so I'll now go to the next slide. So as I just mentioned, there's additional information in the paper. We report the results actually in both the total view that was just seen, but as well we also report it for the NHANES represented population, that residential population, along with 95% confidence intervals that represent the statistical uncertainty in the NHANES data sources as well as the mortality data sources. And we also report the estimate for those additional populations not in the NHANES sampling frame, principally the incarcerated, but also those who are homeless and the unsheltered homeless and those in nursing homes. A number of supplemental analyses are provided in the appendix. These explore the impact of including narcotic overdose deaths in the methodology. So the earlier methodology for 2010 does not deal with the drug use epidemic and partly reflecting the era of the data collection that is being reported on. But we wanted to really understand how this change in the methodology might be changing the results, and so that's gone into. We also explore alternative weighting schemes for how to understand how to put together those hepatitis C and overdose mortality maps. We also look at alternative methods for thinking about prevalence in the populations not included in the sampling frame. We explore just to sort of give an alternative way of thinking about it and the results for that as well, sort of to help round out the story. As well as a plethora of additional details on how the NHANES and narcotic overdose death data sets were considered and evaluated. As with all models, we sometimes write appendices that are much longer than the papers to really make sure that, that readers could feel confident in the results and the considerations that went into them. So those are all provided in an online supplement. In addition to the results that are displayed in the paper, I want to just make you aware of an important another important source for information related to this work, and that's hepfu.org, which is a website run out of Emory University, and it's really in a partnership with Gilead Sciences, and it's related to the AIDS View project, and for people I'm sure are familiar with both of these. And it's an interactive online resource for mapping data related to the viral hepatitis epidemics. This website is a great resource for our earlier work, but it also shows key social determinants, mortality data, and other data sources related to hepatitis C. And the reason I'm raising this now is that our friends at HepView are using the data that's being released today as part of a new release of HepView that's going to be in mid-January, on January 16th, that will feature the new estimates from this paper as well as other new data sources that help to contextualize the epidemiology of Hep C in states and really changes, sort of important changes in epidemiology. So the results coming out today will be available to explore and alongside these other data sources as well. So I just want to make sure people are aware of that. So just to really close this out, some important limitations to consider. This is all a model and survey and model-based analysis. So this is not a census of all infections, which is really impossible for hepatitis C. So we have to be cognizant of where our assumptions are. One of them is that NHANES may be limited in representing hepatitis C increases among the hardest to reach populations, such as persons who inject drugs. And I'll say we're reasonably confident that the survey is capturing a degree of this population. There's a number of side analyses in the paper that go into this, but we do think that the survey does seem to be noting increases in prevalence among younger persons. But there's still a strong possibility that the survey is still not fully representing these hardest to reach groups. The other is that hepatitis C and narcotic overdose deaths, as we included them in this analysis, may not be full proxies for areas of underlying hepatitis C infection. There's a number of ways we can think of where state level or even county or smaller levels of intervention may be causing changes in how these represent underlying prevalence. The other piece that is the one that I mentioned earlier, which is that these results represent an average during the 2013 to 16 period. This is certainly a time of rising incidence, and of course there's ongoing trends that may be reducing prevalence, such as mortality and treatment. And so this is a snapshot still of a few years ago. And it's very likely that increase may yet have been rising since 2016. Other indicators would point in that direction. And so it's important to remember that, that this is a period prevalence for those years. I think there's some strengths that are worth noting here, that this is a synthesis of large national data sets, essentially all NHANES and all death certificates during the 1999 to 2016 period. So it's really a synthesis of all of the publicly available data that could be brought to bear for this question that's sort of publicly available. And it's using a lot of local information, which is the vital statistics data. The model doesn't have that many assumptions, really the ones that we showed you earlier around weighting and the different inputs to it, but it's sort of a relatively transparent modeling approach. And it also, using a common platform of methodologies and data sources, really facilitates comparisons between states. We recognize that a number of jurisdictions have their own efforts to look at prevalence that may bring to bear other data that are locally available. But this approach gives another alternative, either cross-validating with those approaches, but also providing comparisons between states to really understand jurisdictions that are more or less affected and how we should think about our national epidemic accordingly. So just in conclusion, national surveys such as the NHANES in conjunction with our local mortality data that can capture multiple aspects of the epidemic really now enable a full and systematic view of prevalence in states. The highest rates of infection were observed in areas with histories of infection, of hepatitis C infection and historical injection drug use, as well as states that are more recently deeply affected by the opioid crisis. And we hope that these estimates are useful in the work that you do, be it to benchmark where your epidemic's at or to guide prevention, diagnosis, and treatment efforts. And with that, I'm going to pause and thank all of our collaborators at CDC, Emory University, and University of Albany, and recognize once again our support from CDC to conduct this work. And with that, we'll start taking questions.
And ladies and gentlemen, if you would like to ask a question over the phone, you may do so by pressing *1 on your touch-tone phone at this time. Again, that is star and then 1 if you would like to ask a question over the phone. You are also welcome to use the Q&A feature on your web platform at this time. And we'll pause for just a moment to give everyone a chance to signal. And we do not have any questions in the queue over the phone at this time. Do we have any questions coming in over the web today?
No, we do not.
Okay, once again, ladies and gentlemen, that is *1 if you'd like to ask a question over the phone. And I'm sorry, sir, you were going to say?
Oh, I was just going to quip that it's the Friday before vacation, so I understand if people don't have questions. We have one question that's been written in. Do we anticipate much media attention to the findings? And I'll say that the journal has sort of today released some information to media, and I do anticipate some pickup. I've spoken to one reporter with one of the news wires, but given the timing with the holidays, we sort of all collectively decided that this really wasn't the best time to push out the information, frankly, and that there is, with the activities surrounding HepView and their data coming on board in mid-January, there will be more attention to this work placed around then. But I'll say that, yeah, the timing of this was not really our choosing and not particularly ideal, so we're sort of limiting the outreach here. And I think that's, in a sense, fortuitous, so that it can give all of our partners, you all, time to work with these results and prepare how you'd like to position those.
Okay, are there any other questions that have come in?
Yes, we do have a couple of questions that came in over the phone, if you'd like to take those.
Yeah,
okay.
So the next question is about rural states. And particularly, the question was, in rural states, including Iowa, injection of meth is more prevalent than opioids. Any thoughts how this could impact prevalence? So that's a really great question. And I'll say I don't have data to sort of fully back up what I'm going to say, but I think that the transition towards injection of meth is a more newly emergent pattern, even in the last 2 years. And so during the interval that's being captured, I would say that's probably less of a limitation. But if we were to redo this today for capturing the most 2 years of data, I think we would additionally need to think about that, because it is an important piece. We're on some other work that we're doing here with persons who inject in New York. This has definitely been an issue that's emerged, that it's really the fluctuations in the drug market are very hard to keep up with for this work. So I think that's really important.
Okay.
The next, sorry.
Did you want to take one or two questions from the phone, or continue with all of the web questions first?
If there's phone questions, that's great too. There's a third write-in, so I was going to address that as
okay.
well. Okay, so the last question is whether there's what's sort of the plan for partners, and NASTAD wants to share the information, and so I want the real question really is about what's sort of the communication strategy, and I think I might turn to Blythe to sort of answer how this is being dovetailed with NASTAD.
Eli, can you repeat? I can't see the question. Can you repeat the exact question again for me?
Sure. I was wondering what your plan is to share this information. E.g., is there a partner letter coming out from CDC? NASTAD would love to share this with our members, but want to wait until more formal communication comes out.
Yeah, and actually, D'Angela, are you still on the line? Do we have a letter planned for this? I'm not aware of a letter currently, but it's certainly something we could do.
Yes, I'm still on the line. Can you all hear me?
Yes.
Okay. So from the Division of Viral Hepatitis, we are planning to have a Dear Colleague letter to come out that'll be signed by our division director. And so all of our activities, we're planning to align them with university, with Eli's group. So the Dear Colleague letter is due to come out, and then we are also planning some social media activities utilizing our current Twitter account.
Great. Thank you, D'Angela.
Sure.
Great.
So Eli, you want to take some on the phone? Why don't you take some on the phone now?
Sure.
Okay. We'll take our first question from Nicole Valdivia from the Iowa Department of Public Health.
Hi, actually I had written in a question about rural states and meth, so it has been answered. Thank you.
Oh, great.
Thank you. We'll take our next question from Karina Dan with HHS.
Good morning, and I just want to thank Eli and his colleagues and folks at CDC for supporting this important work. It's really pretty amazing. What I was wondering if you have had thought about whether this kind of analysis should be repeated, what in fact the recommendation would be to kind of track over time in a more, I guess, timely fashion than we've been able to do before, since this is fairly new and compared to other prevalence estimates, fairly recent data. So is this data, since the design of the analysis is already done, does that make it a little bit easier to do an update, or is that going to be kind of like every time you have to put that same amount of effort into the analysis?
Thanks, Karina. It's great to hear from you. I'd say if the methodology is replicable, I think where we really come down on the limiting factor is the data, right? So NHANES data comes out in sort of 2-year chunks, and there's sort of the method is generally not sensitive enough to short-term changes. The other one was even just what was mentioned a moment ago about changes in the risk factor, and so so I'll say it can be repeated every several years with some degree of validity. But I think that we really need to think about improvements to surveillance through other means in order to complement this. I think many of us would like shorter-term answers. So,
would you say that this hepatitis C surveillance is probably the weakest link of the data sources that you used?
So I'm going to respect that many people dedicated to hepatitis C surveillance are on this call. I'll also say that we didn't directly use local surveillance data in this work. That it's a very sort of top-down approach, and a number of efforts, such as one recently reported by colleagues in New York City, adapt another approach, which is sort of to go in the other direction, which is to start up from case surveillance and add infections possibly missed back in. And I think that there's a lot of worth in sort of going in both directions. But I'll say that the idea, I would love a more robust, comprehensive surveillance program where we really could have every jurisdiction at a very high degree of completion, and that would really open up more doors for estimation. Absolutely.
I meant absolutely no respect. The surveillance for hepatitis is a gargantuan job, and I'm not sure where to start. But thank you. Thank you very much.
Yeah, and I want to add something. This is Blythe. I think, again, recognizing that prevalence, that's the estimate that, particularly policy partners really want to know, and the media often get very excited about, but it's the hardest burden estimate for us to get. Even if we had a census of all hepatitis cases in the United States and manage that over time, it's still quite challenging to estimate prevalence, given that it's dependent on deaths. So you'd have to have regular linkages to vital statistics data at the local and state levels. And as Eli mentioned, I think there are some states that have the resources and capability to really try to better estimate that using surveillance data. But it's even for the best resourced areas, it's quite challenging. And so it's just something to keep in mind that it's not a failure of surveillance per se. It's more a challenge of the estimate we're trying to get at.
Yeah, absolutely. I think you're right. Even with complete diagnosed case surveillance, right, we still have to account for infections not diagnosed. And as we all know, at least from the HIV example, that's a gargantuan challenge, and that's with a much lower undiagnosed rate. So lots of work to be done on all sides.
Yeah, and then also treatments, which is the kicker, and good news for hepatitis C, but becomes even more challenging for hepatitis C in particular is that we're curing people. So they're going to come out of our pool of prevalent cases, but we have to, if we were to use the surveillance system to get at prevalence, we'd have to follow people over time and ensure they reach SVR, and so it is quite challenging.
Okay.
So we have one more writing question. Sorry.
Okay, please go ahead. We can take the question from the phone in a minute.
Great. So this one might be better with more of an email follow-up, but basically the question is, how does this intersect with the body of work that CDA is doing? So that's the Center for Disease Analysis based out of Colorado. And the question is, we have a different prevalence from their work, and how do we best use both sets of these estimates in our state? So it's hard to comment in particular. I know in general how the work, so CDA is an organization that does dynamic modeling of hepatitis infections, and essentially it's a simulation approach where prevalence in the past is modeled into the future in order to project future prevalences of infection. So I'll say just methodologically, the two approaches are different. This is our analysis is more of a single time point estimate rather than a population simulation model. The other point is I'm not sure what the inputs to the CDA model were, but often in the models that they've conducted, they do start with an NHANES-based prevalence. And so that at least some time point in the past in that model that you worked with them on, they probably we're using an estimate that was rather related to the one that we're using. Where things may diverge really may get into some of the modeling choices and parameter input choices that were used in that model. So it's hard to specifically comment other than to say the approaches are complementary and sometimes intersect, and where they don't intersect, we might need to see the details. But I'm sure a number of other jurisdictions on this call have worked with them, because I do know that they've worked with a growing number of states over the past number of years.
Okay. We have a question over the phone from Shauna Onofre with the Massachusetts Department of Public Health.
Hi, thank you for this presentation, Eli and the rest of the co-authors. I know that we've talked about this quite a bit, and I really appreciate the conversation that just went on regarding hepatitis surveillance, because as you know, I have some concerns about what this estimate looks like for Massachusetts compared to what we see in our surveillance data. And I know that concern has been echoed by many of my colleagues who are working in viral hepatitis surveillance. I'm really looking forward to reading this paper once it comes out, but I'm wondering if you address the concern that many jurisdictions have that this may be an undercount in some ways of actual prevalence in different jurisdictions.
Yeah, so in the global sense, we don't specifically have an answer to that possibility. We do talk about sort of the various ways that NHANES sampling may or may not be limited, and there's several sensitivity analyses to think about the undersampled populations. The other thing but it's sort of hard to comprehensively address that in the space of the paper, but we definitely point out where local estimates have given different pictures, and really understanding that there's a lot of ways to think about to sort of get at this pretty latent quantity of prevalence. So we talk about it, but we need to keep the dialogue up and both like further we all need to sort of further develop our methods and data sources, and hopefully we're going to converge around truth. That's what I'm hoping, and we're going to throw a party.
And
We
we'll
probably have time for one more question, if there is one.
We do have one, and we'll take our final question from Umina Khatun with New York City Department of Health.
Hi, it's actually Ann Winters from New York City. So thank you very much, Eli, for the presentation. And I had a question and a comment. One question I had was, when you adjust for Hep C related mortality, is that, you probably mentioned this, but is that any Hep C mentioned on the vital stats record, or is that Hep C as cause of death? Like if a young, I was just interested that the Kentucky example, the Hep C related mortality was higher than the national estimate, and is that related to overdose? Like they overdosed and they have Hep C, or is that Hep C as cause of death? That was my first question, and then I also have a surveillance comment, of course.
Hey, Ann. Okay, so in the cause of death aspect, it's any contributing cause of death, so primary or contributing. But it has to be deemed by the physician to be sort of part of the mortality process. So, that's what it is. I mean, I'll say that in the first analysis of this work, we explored the veracity of that data quite a bit and really tried looking at alternative case definitions rather than just direct reports of Hep C on the death certificate because of the propensity to underreport. And basically, no matter what we threw at that, it didn't really change the end result on prevalence estimates too much. But with 2 minutes left, I want to make sure you have your time for your surveillance question.
Yeah, thanks. So, we also have talked a lot about the different methods, and, in New York City, we're using the surveillance-based method. And I just wanted to respond to the comment before about some of the limitations to surveillance and really understanding the impact of treatment on surveillance. And I think, New York State in 2008 published an NHANES-based state estimate and really called for improving surveillance to really improve our understanding of prevalence. And I really think that in addition to using NHANES for jurisdictions that don't have good surveillance, there should be really great emphasis at the national leadership level on encouraging and enabling states to develop their surveillance abilities, including negative RNA reporting, because that is a proxy for treatment initiation. And there may be questions about it, but we've looked at that in our own data. You also are aware that AbbVie led this initiative with some others to do mapping Hep C, and they are using negative RNA reporting as a proxy for treatment initiation. And I think we just can't continue to talk about the surveillance limitations and not really allow states and jurisdictions to develop their capacities. It's just so critical if we're really going to do anything about this. So that's really just my final comment.
Eli, I'll take that one as a part of CDC leadership.
Yep.
I completely couldn't agree more. I think we are constantly looking at ways we can try to improve surveillance. I mean, it is the cornerstone of everything we do in public health. I come from surveillance, I come from cancer registries, and believe strongly in the importance of it. It's often difficult to make the argument because it's not as sexy as some of the other things that we do. But you have an ally with me for sure, and I suspect with new leadership in our division, you'll have the same with them. But we agree surveillance needs to be improved, not just for prevalence, but for many reasons, and we'll continue to make the case for improving surveillance.
Thank you.
So, well, thank you. So I think we're out of time. I want to thank Eli for the great presentation. I want to thank the participants for taking the time to listen and the great dialogue we've had here and even before this on individual calls. Our state partners are invaluable to everything we do, and we do want things to be helpful and not a hindrance. So always appreciate the dialogue. Eli, did you want to say any closing remarks?
No, No, really, thank you, Blythe, for hosting us, and just also wanted to echo Anne's plea. I think we're all in agreement that that better surveillance is going to give us clearer pictures. So, yeah, thank you all.
All right. Wishing everyone a Happy New Year and whatever holiday you celebrate. We will have more discussions in the new year, I'm sure. Bye-bye.